how many in here, now this is really going to be much more on the hospital side than the physician staffing, so we're really going to talk about the nursing staffing. How many still has shortages in nursing? Still quite a few. I gave this talk last year, I've updated it, and so this next slide was interesting. So 2012, these were on that side, that was the top states with their nursing shortage. And then, since I gave the talk last year, they released on 2017 a study that was published last year. Look at the decrease in that. Really amazing. I know when I was still in a health system, it was becoming very creative of how were we going to bring nurses in. Because the nursing shortage that we were facing by 2020, at that time in 2012, has now moved kind of to 2030, interestingly enough. It's very interesting. And then if you look at the map on the next slide, this is a map. On the top is the 2012, on the bottom is the 2017. Everybody was getting better with the exception of New Mexico. Anybody from New Mexico? Yeah. They said it's mainly your aging nursing force, where a lot of the other states have developed systems. You're the only one that went down. You are actually rated higher in the first study than you are in the second study, but it has a lot more to do with your nurse population there, and you're not getting the new nurses in that a lot of the other states are working very closely with different college, nursing schools. So I don't know if you have less nursing schools there. It didn't say that. It was mainly just gone to the age of your nurses. So what I'm going to do is we're going to go over this. I'm going to give you a case study of how to make a financial pitch to your leadership. And for the executives in the room, this is done. I worked with when I did this, and I did it in conjunction with some of my other vice presidents that I worked with across the state of Texas. But we came up with this model of how are we going to give safe patient care in the emergency department. And what do we need to do? Now, you all need to look at this and really be considerate of what your state laws are, and then get buy-in very early from your executive team. But I literally look at the nurse extenders. How can we get an RN extender? Who are they, and what should they do? And that's what we're going to talk about today. This is from 2017 EDBA for non-nurses. This is the ratio, and you can see across this is the volume bands by the 20,000 bands, so it's 20, then 40, then 60, and so on. And you can see what the ratio for a non-RN is to that. And you can see smaller ones, they're up high, and then they go down as you increase in volume. And then they go back up. So the average for all of these within the EDBA is 1.14. And then pediatrics was actually the highest at 1.51, non-RNs to patients. So I thought that was a very interesting data from that standpoint is I know in all the ERs I've worked at over my career, it never felt that high, with the exception maybe back in the 90s where we still had CNAs in the department and orderlies. You remember the orderlies? We had those in there too. So, but again, keep this in mind as we go through the talk today. So what do you have to do? First of all, know what your Board of Nursing says within your state, because some states are much more liberal than other states on what they allow and don't allow. Considerations, really look at your paramedics. Now, in the state of Texas, when we were doing this, they actually passed a state law that paramedics within the emergency department could practice to their full scope. So what does your state allow? And so it took a long time for the Board of Nursing and sometimes to come along with that, and the ENA. How is the ENA in your state supporting this? What about an LVN or an LPN? What can they do? And how many of your magnet are on the magnet journey? Because this has a lot to do with this discussion today. I'm going to talk a little bit more about the impact of this model on that journey. And then techs. Now you notice I don't have CNAs on there. Most ERs that I've come across don't use CNAs anymore, and that's because they're limited by usually the state what they can do, and they just don't help within this area. And so a tech, most of the time, you can take a tech, whether it's a medic, paramedic, or you just within your state, it allows you to have a course internally to develop that tech And there are states that allow that. Depending on your competencies, you have to have the competencies and all the checklist, but it actually allows them to go all the way up to giving, starting drawing blood, doing AKGs, and things like that. So it's, again, what do your state? Early buy-in from your executive team. What I did is at the division level for us, I got our CFO engaged early because I knew what I was going to do is I was going to ask for the taboo. I was going to ask for more FTEs. Is that not like the worst thing in the world to do? So I got him on board early. And the other thing is we got our division chief nurse involved early on. So you need to look at that and get them involved. The other thing is I got our HR involved, our vice president of HR involved in this. And we had a task force. We had a task force within the area that I covered, but also then we had for statewide because we had multiple hospitals in the state and divisions. And so we would, each task force for each division would talk, and then we would come together so that we were creating a robust that took into consideration E&A state laws and the CNOs. So know what's out there too, because what we found in the Houston area, we might have had a lot of medics that were available, and I'm going to say medics to include all levels of within the medic realm. But yet in Dallas, they didn't have that, and we, but they, let me reverse that. They had more medics, we had more LVNs. So what do you have available? It doesn't do any good to try to create a model if there's not out there any potential extenders for you, because how you develop it will depend on their skill set. So geographic care teams, this is one of the things we look at. I'm old enough as a nurse when I first went into it, first we didn't have it, then we had it, then we didn't have it, that cycle that we go through, those of us that have been around for a while. But a geographic care team does not have bed assignments. This is very hard for our nursing staff and sometimes our providers to get beyond. But we're going to have an area and the care team is going to care for that area. And generally you have to look at what is your department layout, because I'm going to show you a floor, just a regular ED kind of like, but that can be a barrier to coming up with geographic zones. And then you look at trauma critical care. Are you trauma? What level of trauma are you? What kind of critical care unit do you have within the department? Look at your arrival patterns, because that's going to depend upon the geographic zones when they open and close, like Dr. Welsh talked about earlier, and then a low acuity area. So this is our test. We're going to go through this example. You can take what I have in here and modify it for your own ER. I have numbers and everything in here, so all you got to do is plug your numbers in and make adjustments, and if you want to go forward on this. So this is a 32-bed community hospital. Has 17 beds in the main ER, 2 which is critical care or code beds, 15 rooms, and then room 17 they hardly ever use because of staffing. And then low acuity had 6 beds plus another 6 beds that were never used. So right there you can see there's 7 beds that this ER never uses. And then you have a CDU overflow unit. And depending on what was going on, I'll be honest, it would depend what this was used for. And so that had 7 beds. And a lot of times it was closed and only open during their peak seasons. This is the flow map. You can kind of get an idea of where they're at. So you have your low acuity area, your CDU, and then your main ED. So let's make some assumptions. And again, you can change these assumptions to what fits to your emergency department. A 1-to-4 ratio for RRNs, which is pretty typical across the United States. 2.2 hours of nursing care per patient, which is pretty normal, can be generous in some areas, but not as much in others. We're going to do 100 visits per day just to make the math easy, which is 220 care hours, and that's going to be 18 staff members in a 24-hour period. And our assumption is everybody works on 12-hour shifts. So that means our traditional nurse staffing model is you have a charge nurse per shift, a triage nurse. In your main ED, you have 4 nurses, or 8 RNs that work 12-hour shifts per shift. So you have 8, and then you have 16 over a 24-hour period. In the low acuity area, this particular hospital only has it open 12 hours a day with 2 RNs staffed in that 12 hours. Because again, it was an area, remember, most of the time in nursing, we never staff it with 1 person. From a safety standpoint, you always want 2 people in there. So there's just a graph of the same thing kind of showing down from the standpoint. So you look at your 24 hours a day for a charge nurse, 24 hours for a triage nurse. Your RNs is 124 hours, techs 24, unit clerks, if you have them around the clock. Most places with 100 patients a day probably don't have 124 hours a day. And then, so that's a total of 220 hours and 18 people. So that's how I got to 220 and 18 people. These are your traditional assignments. So you have the charge nurse, who hopefully doesn't have a patient assignment. Rooms 1 through 4, 5 through 8, 8 through 12, you can see. And then 17 is not used in this one particular one. So there's 10 in the main ER with 2 techs, 10 RNs, 2 techs, over a 24-hour period. And then this is the low acuity or fast track area and triage. You got 1 triage nurse, you got your 1 rooms that are open, the other ones that are closed. You have 1 tech for the whole area, and so you need a total of 6 to cover that in a 24-hour period. So nurse extenders, this is again where you have to take time to really design this. Because our physician partners have done this many, many years ago. You came up with extenders because of the need that you had to have to work with the patient population. It is not so far-fetched that within a emergency nursing that we should not be looking at this. So you want to look at the scope, their skill mix, and delegation. This is one of the things that we took a lot of time on, is delegation. We just happen to be so lucky in the state of Texas that the Board of Nursing has a great delegation packet. If you're looking at this, you're not in Texas, just go to the Texas Board of Nursing. They have a great outline of what RNs should delegate to. We made sure that our physician partners understood that, because a lot of times they don't know if you have physicians in your department or APPs in your department that have never worked with anyone outside of the RN skill mix. They're not going to understand what can they delegate and what cannot be delegated to that. And then, again, your arrival patterns, so you know what your shift needs are. Okay, the care team generally excludes the trauma critical care bays. And really what I still like to stick to that 1-to-2 ratio within that area. So depending on how many beds you have in your critical care trauma area, I still like to stick to that and not mess with that. Can have a provider in the geographic care team. I prefer that. I've worked with a lot of different hospitals that had that. I think it's very good, especially in these large emergency departments that are becoming very, very large. Breaking that out and having a team that arrives at the same time. So if you have to expand and collapse your ED because of arrival patterns and capacity, then you do that as a team. So if I have a pod or a zone back here that I'm going to close at night, that means it should cover for the physicians so our physicians don't get overworked. And then, again, you're going to base it upon your arrival pattern. For this particular one, at this time in emergency nursing, I recommend 1 nurse to 1 extender. I think if we continue down the path that we can continue to have RNs in emergency department, I think this is a good model. But when you look at some of the shortages in some states, it may be 1 RN with 2 extenders and expand the beds. Because again, it's going to get to a point, and really what I want to do is get the RN back to managing. We learned as RNs that we are managing the nursing care, but too often we have become task-oriented. And I see that with a lot of the new nurses that I had in my departments, is they really didn't know how to manage nursing care anymore. It's just, I'm tasked, I'll do this task, I go to this task, and they forget to think about the care. And our physician partners really rely upon the RNs to help give them that information. We've heard a lot from our more experienced physician leaders today and how much they rely on RNs, but a lot of the newer ones don't have that skill set anymore. So getting back to what does an RN have to do that no one else on the care can do? They have to do that initial assessment, and they can delegate the appropriate task. So then if we bring in our task, our extenders, or nurse extenders, to do the task. And again, depending on your state and depending on your organization, you let them work to their full scope. It's a great job satisfier. Too often we bring in paramedics, and sometimes it's because the state limits what they can do or the hospital limits. Just because in Texas they said they could do to their full scope didn't mean the hospital was going to let them do that. Now, we chose not to in the Houston market. The Dallas market chose to. Our physicians' leadership chose not to because what they wanted was to make sure the nursing staff had the extender. They felt that the way the legislation was written, then that paramedic became a physician extender. Because if all of a sudden they can, intubate and do all these other things that they do in the field, they're no longer falling within the nursing area. So that's what we did. But again, you have to look at what you can and cannot do within your state. This is where I'm going to stop and say, CNO buy-in is very, very important. If you're on the magnet journey, this is one of the biggest barriers that we had, was the CNO understanding of what we were doing and why we were doing it was very important. But if they were on the magnet journey, there is a thought process that you'll have to have RNs. And I spoke to many, many magnet evaluators, and none of them said, they said this was a great program. They would actually love to see this program when they came to look for magnet and give you your magnet status. There is nothing in there to say how many nurses within the ED has to be an RN and how many can be without. They're never saying within magnet that you can't have assistance to the RN. It's a lot more to do with your education level, that within how many BSN, MSN, RNs do you have within your organization, as opposed to non-licensed. So CNO is very important. We found where it was successful is where we had progressive CNOs that were willing to go down this path. It was how did we communicate that to them. The CFO was much more excited about this than the CNO. That's pretty odd, but it was, because I'm going to show you in a little bit how much we save money. And so bring them in early on. Charge nurse, so again, this is our staffing model for the main ED. So we're looking at one charge nurse. We're looking in our critical care rooms, one nurse, but when their rooms aren't busy, they're going to be afloat. Too often, the person that has that assignment just sits there and waits. They need to become afloat. And then one RN, with the exception of the rooms, if you think in a 24-hour period in Team C is going to be half because we're only opening up those rooms for 12 hours a day. And then you see the extenders. We're bringing a lot more extenders in to support that nursing staff. We're not changing nursing here. We're adding an extender to support to do the task for the patients. This is our low acuity triage area. And again, bringing in much more. This is one of the areas when you look at your intake, I really don't like triage, that's my personal thing. I think we have outgrown triage in emergency nursing. So if I have any ENA members or board members in here, it's just my personal thing. I think we've created barriers by having triage. We've gone beyond of what triage is supposed to be, so I think it's time to pull it back in. And so there's some different models with this. But again, if you have a physician in triage, I still want an RN up there in the intake model. It's just how do you use that RN? I've seen in Florida, I went and visited a hospital in Florida, an ER, and they had a paramedic in that role because they weren't doing a full triage assessment anymore. Again, state, hospital, and union. I didn't talk about union. What does your union allow? If you have a union in your hospital, you've got to have them on your design. Whoever your ED union rep is, when that task force you develop it, they have to be there from the beginning. They're going to buy in it if they're part of the answer. Because again, if they're representing the RNs, this is to make the RN life easier. But if you don't include them, you'll have a fight on your hand when you go to include it. And I talked about the HR and CNO on that. And you have to have that because you're going to be developing job descriptions. Because say that you have a tech already within the department. We had techs, but we turned them into extenders. Because as we comb through all what the paramedic laws said and all the medic laws said and the Board of Nursing, we created a job skill list. And then what we did is then we looked at what was their current skill list and what could they do under this. We did bump up their pay. So with that, as we were going to transition from a tech to an extender, then it became that they had to have these certain skill sets. We had the competencies, but they got paid more. and you'll see that in another couple slides. The other thing in the example we did, remember we had the 7 beds closed? We've now opened the 7 beds. Our new staffing model has given us 7 additional beds that were closed almost every day due to staffing. We didn't talk about the CDU or holding area, whatever that was. We left that alone in this example. Look at your data. What does your data tell you? Now, when I'm talking about data here, what is your RN vacancy rate? You have a high vacancy rate, but more importantly, what is your fill rate? It is very different if you have a 10% vacancy rate and you have a fill time of 30 days or a fill time of 120 days. A very different model, because if you have the 120 days, what are you using? Agency nurses. It's taking way too long to get that new person in. And so that tells me there's probably not enough RNs in your area. So again, if you have a high fill rate, a high vacancy rate, again, this is something that you should look at with your leadership team. How much money do you spend on agency and travelers annually? If you're still using those, because I know most of us are trying to get away from that for a multitude of reasons, not just the cost, but quality outcomes and your operational outcomes are generally not there with travelers and agency. What is your satisfaction scores? And then what is your left without being seen rate or being treated rate? So financials. Now we're going to switch over to financials for the business people in the room. Again, I keep going over about the rules. I just can't stress that enough, because we had, in Colorado, we had one of our partners in Colorado did theirs. Very different rules in Colorado than we had in Texas. So it's, again, you have to know what you have. And again, you're bringing in your executive team. I just add the CFO in on this. Consider how you're going to use the areas and the time. And then, so this is what, I remember our 5 states early on. This is their average salary for an RN. So of all of those, it comes to $35, about $35.50 an hour of what an RN is making. Now, if you're going to add, because we added 4 extenders to, so 4 FTEs, if you are 4 people, over 24 hours, and we converted those techs to extenders. So our average tech was making $18 an hour. Multiply that times 4 for 12-hour shifts, and you come up with $864 a day, or $315,000 annually. Now, I'm going to bump up their salary because they're going to be doing more. And they went up to $21 an hour, which then you can see that breakdown. We didn't add any additional RNs. This is only extenders that we added. But again, you know, adding those 4 people on a day is a lot. And, you know, it's a big ask in any institution. So there's $129,000 annual salary difference, which really in the scheme of things isn't that bad. You just have to show how you're going to pay for it. That's what we're going to do next. So our assumption is that the traveler's annual cost was $450,000 a year. They lost $1.4 million, and you can see my thing for the walkout rates. And this is very conservative. But again, see where you can plug your numbers into here. So we're losing $1.4 million. Our turnover rate, orientation cost, is $42,000 per nurse. So if you have a high turnover rate, again, you can get these numbers from your HR. If we opened up 7 additional beds, 12 hours a day, and see 3 more patients per day, we come up with another $5.7 million annually. So we have a potential for $7.5 million annually to pay for, see if I get that $129,000. So see where sometimes in healthcare we get so much into the FTEs that we don't look at. We're having bad outcomes, bad satisfaction, high turnover, because instead of adding in that almost $130,000. So again, look at your current rate. You want to know what your rates are. What is your prediction in your state for your RN shortage? What is your state doing? Not just the state, but each of your health systems doing to fix that shortage? What are you doing in your department to fix that shortage? When I was still at the director level, I was fortunate enough, because I did live in a state that we had it way back in the early 90s, I went ahead and I had an ED course. I had an ED course that all new graduates, because I could no longer hire experienced nurses. And then we had a high behavioral health issue, and I also trained behavioral health nurses that I hired into the department enough that they could get through and identify these behavioral health patients that waited 30, 40 days to leave if they started to decompensate medically, because that's very different in behavioral health world. So we had to train them to do that. But know what your shortage is going to be, proactive in solving that, but then get the essential buy-in from your executive team. Any questions on this? Yes, ma'am. Because the RNs were just going back to doing the initial assessment and really delegating the task to the extender, they were okay with that. The satisfaction for the nurse actually goes up. With some of your younger nurses fresh out of school, you may have to train them this, because I don't know that we're doing a good job in nursing schools anymore training them on on the nursing management side. So the more experienced nurses were happy with it once they understood delegating. But again, delegating in emergency nursing has really gone by the wayside. So you have to be very careful. And I will tell you, we made everybody sign off in the department, no matter their level. Even lab radiology had to sign off on delegating, so they understood the different roles of what they could and couldn't do. Because in the end, I'm very serious about protecting my RNs and their license, but the same thing has to be for our extenders.